Our topic today is about the pancreas and the endocrine pancreatic tumors. Let's start with the anatomy of the pancreas. As we know, the pancreas is a retroperitoneal organ measuring about 15 to 20 centimeters in length, lies against the L1, L2 vertebrae and posterior to the stomach. It is divided into head, neck, body, and tail. The head, which lies in the concavity of the duodenum, the tail reaches the hilum of the spleen, and the neck is related posteriorly to the terminal part of the superior mesenteric vein and the beginning of the portal vein. The pancreas has two ducts. The main duct, which is the Wirsing duct, and the accessory duct, which is the Santorini duct. The blood supply of the pancreas is the superior pancreatico-duodenal artery, inferior pancreatico-duodenal artery, and the pancreatic branches from the splenic. The function of the pancreas is the exocrine part, which consists of the pancreatic juice, which is about 2.5 liters per day, activated by the secretin and cholecystokinin. The serum amylase level is about 200 to 250 somogai units, half-life in 24 hours. The endocrine part is the function of the islets, which is distributed numerously in the tail. The weight of these islets is about 1 to 1.5 grams, and it consists of beta cells, which is about 65 to 80% of the cells. They are responsible for the production of insulin, which is an anabolic hormone. The alpha cells, which are 15 to 20% and responsible for the production of glucagon, which is a catabolic hormone. The delta cells, about 3 to 10% of the cells, are responsible for the production of somatostatin, and the pancreatic polypeptide cells, about 1%, which are responsible for the production of the polypeptide. What about the congenital anomalies of the pancreas? The pancreas may be totally absent, which is incompatible with life. There is also ectopic pancreas, which is called heterotopic, accessory, or aberrant pancreas. Its incidence about 0.2 to 2%, mostly located in the distal stomach, duodenum or jejunum, Meckel's diverticulum, and less frequently the biliary tract. And according to its presence, it may cause symptoms, as it is mainly asymptomatic, but it may present with pseudocyst, GIT bleeding, gastric outlet obstruction, biliary obstruction, and jaundice. The annular pancreas, here the pancreas is surrounding the second part of the duodenum proximal to the ampulla of water, and it is firmly attached and embedded into the duodenal musculature. It causes vomiting with or without bile, and it has a double bubble sign at a level of the duodenum. Its treatment mainly is duodenostomy or duodenojejunectomy in cases of vomiting. What about the endocrine pancreatic tumors? In general, they belong to a group of tumors called the apodomas, which are the amine precursor and uptake decarboxylase tumors. It is associated with men type 1 multiple endocrine neoplasia, which includes also the parathyroid adenoma, pituitary adenoma, peptic ulcer. The 4 P's: pancreatic tumors, parathyroid adenoma, pituitary adenoma, peptic ulcer. About 35 to 50% of the endocrine pancreatic tumors are malignant. 20% are non-functional tumors. They are commonly located in the body and tail, except the gastrinomas. They are small and multiple. We are going to start now with the Insulinomas, which is the commonest endocrine pancreatic tumor. It arises from the beta cells, solitary, but 10% are multicenteric. 90% are less than 2 centimeters in size, which means it is a small-sized tumor. 95% are benign tumors. The clinical picture, it is characterized by fasting hypoglycemia and neuroglycopenic symptoms. The CNS symptoms include the diplopia, blurred vision, hallucinations, epilepsy, unconsciousness, and there is sweating, hunger, nausea, and anxiety, and these are due to the release of catecholamines. There are permanent neurological deficits with behavioral changes may occur, and it may present also with weight gain or overeating. There is a triad is characteristic for the insulinoma diagnosis, which includes the attack of hypoglycemia in fasting state, in which blood sugar below 45 milligram percent during this attack, and the symptoms are relieved by glucose. How to diagnose insulinomas? The laboratory investigations include insulin radioimmunoassay, which means that plasma insulin level is increased above 7 microunit per milliliter, increase proinsulin per insulin ratio more than 20%, increase the C peptide level more than 1.2 microgram per milliliter with the presence of plasma glucose level less than 40 milligram percent. Plasma insulin per glucose ratio is more than 0.3. Increased C peptide demonstrates the endogenous secretion of insulin, and so it excludes the fictitious hypoglycemia induced by insulin injection. How to locate the tumor? we use mainly the endosonography, the endoluminal ultrasound. We can use the MRI, celiac angiogram, and the blood sugar level is one of the investigations. Treatment. Surgical treatment is done by enucleation, often distal pancreatic. The medical treatment. We use the medical treatment in unfit patients or patients that do not want to undergo surgery. The drug of choice is diazoxide, which decreases the insulin by its direct effect on the beta cells. We may use the beta blockers, phenytoin, verapamil, steroids, growth hormone, all to control the hypoglycemia. Octreotide may decrease the insulin secretion. Also, the use of calcium channel blockers decrease the insulin secretion. And in cases of secondaries or metastatic disease, we use the streptozotocin. The gastrinomas, which is called also Zollinger-Ellison syndrome, it arises from a type of cells, G cells, which increase the secretion of the gastrin from the GIT. The commonest in men type 1, and it affects males more than females. 50% are multiple and malignant, and it causes Zollinger-Ellison type 2 disease. Gastrinomas are located in a triangle called the Passaros triangle or the gastrinoma triangle, which is the junction between a point at the junction between the head and neck of the pancreas, another point at the junction of the cystic duct with the common bile duct, and the third point is between the second and third parts of the. The clinical picture is characterized by multiple ulcers, resistant ulcers or refractory ulcers, recurrent or jejunal ulcers. And these ulcers are prone for bleeding and perforation, associated with diarrhea, steatorrhea, and hypo. In the diagnosis for the lab investigations, we do the gastrin assay, which is more than 200 picogram per milliliter up to 1000 picogram per milliliter. Calcium provocation test, more than increased gastrin level. Pentagastrin test shows increase in the basal and peak levels of gastrin. Secretin provocation test increases the gastrin level above 50% of the baseline. To locate the tumor, we use endoluminal ultrasound, gastroscopy, MRI, angiogram, and somatostatin receptor scintigraphy with radiolabeled octreotide. The prognosis of gastrinomas, the patients with pancreatic tumors have a worse prognosis than those with the primary tumors in the duodenum. But about 60% of the patients are curable. The surgical treatment includes enucleation of the tumors, distal pancreatectomy, pancreaticoduodenectomy, subtotal pancreatectomy, and often gastrectomy. The medical treatment includes the proton pump inhibitors, octreotide, and for the metastatic disease, of course, we use the streptozotocin with the 5-fluorouracil or doxorubicin. The third pancreatic tumor is the glucagenomas, which are the tumors of alpha cells of the pancreas. They are located mainly in the body and tail. It affects females more than males. It reaches large size, 5 to 10 centimeters. Commonly sporadic, 17% are associated with men type 2. 80% are malignant and 80% spreads mainly to the. Its clinical picture characterized by the necrolytic migratory erythema, about 60% of the cases. 90% of the cases have diabetes. There is also diarrhea, weight loss, stomatitis, anemia, vulvovaginitis. For the investigations, the lab investigations, if the serum glucagon is more than 50 picomole per liter, it is diagnostic. For site location, we use the endoluminal ultrasound, MRI, and the treatment. The medical treatment is directed to correct first the anemia and the protein and amino acid deficiency, whether enteral or parenteral feeding. The intravenous amino acids are used to control the necrolytic dermatitis, prevention of DVT. Dacarbazine is effective. The surgical treatment is distal pancreatectomy, Whipple's or total pancreatectomy occasionally is needed. VIPOMA is the tumor of the delta 2 cells of the pancreas. These cells in these tumors secretes vasointestinal polypeptide more than 150 picogram per milliliter. It is solitary tumor located in the body and tail, malignant tumor, and it is called pancreatic cholera or weak T syndrome. Why? Because it is characterized by watery diarrhea with hypokalemia and achlor. The treatment, we use the prednisolone to control the diarrhea, octreotide to decrease the secretion, and distal pancreatectomy is the surgical treatment. Lastly, the somatostatinoma. It is a rare type of endocrine pancreatic tumor, affects females more than males. 80% are associated with liver metastasis. Clinical picture includes diabetes, steatorrhea, cholecystolysiasis. Radioimmunoassay is used for the detection of plasma somatostatin, and the treatment is surgical excision or debulking. Thank you.